I'd like to invite our final speaker for this morning's session, Mashfiqul Hasan.
Thank you. Good afternoon. I'm Dr. Mashfiqul Hasan, representing a study group called Study on Diabetes in Young Group, SODI, from Bangladesh. Bangladesh, a densely populated country in South Asia, where the nature, the landscape, and the resources are not the same. However, we suffer from the same problem, diabetes in young. I have nothing to disclose. So the prevalence of young onset diabetes is increasing in the global context and also in South Asia, including Bangladesh. Due to overlapping clinical features, these individuals are often difficult to assign with a particular type of diabetes. They have been related to autoimmunity, obesity, and even malnutrition. But it is possible that these individuals may be attributable to monogenic form of diabetes. Especially, there are few atypical cases of youth onset diabetes in South Asia who are non-obese, negative for islet autoantibodies, and their insulin secretory defect is more prominent than insulin resistance. But their genetic background has not been well explored in our population. In addition, the global distribution of MODY subtypes varies significantly. So it is necessary to investigate MODY genes in diverse ethnic groups. In this background, the objective of the study was to investigate the frequency and pattern of MODY gene variants among Bangladeshi individuals with young onset atypical diabetes. The participants are recruited from Young Diabetes Clinic of the Department of Endocrinology, Bangladesh Medical University, Dhaka. Young individuals aged 10 to 34 years with diabetes who are negative for islet autoantibodies, are non-obese, and have history of diabetes among the first-degree relatives are recruited in the young diabetes group. Age-matched individual with normal glucose tolerance was included in the comparison group. As a pilot study, the study enrolled 50 participants with diabetes and 50 participants with normoglycemia. Genomic DNA samples were sequenced using next-generation sequencing to identify the variants of 14 MODY-related genes listed here. After proper preparation, sequencing was done using Illumina NovaSeq 6000. Sequencing reads were aligned and variants were called using appropriate toolkits. Then variant annotation and prioritization was done based on minor allele frequency, previous reports in disease literature, damaging effect in silico prediction tool, and clinical features of the proband. Ethical aspects was maintained throughout the study. Now moving into the results. The median age of the participants with diabetes was 27 years, 54% of them were female, and their mean BMI was 22.5 kg per meter square. A large number of variants were detected in 14 MODY-related genes, but only a minority of them were unique to diabetes group and absent in controls, and of them, only 6 variants were regarded as potentially significant. Still, these variants could only be classified as variants of uncertain significance according to the ACMG guideline. So the proportion of MODY in the study was only 12%, 6 out of 50 suspected patients. Here, the identified MODY gene variants are listed. All the variants were heterozygous missense variants. It is to be noted that only HNF1A gene can be regarded as common form of MODY gene in other ethnic groups. The other variants are identified in genes which are related to less common varieties of MODY. In disease database, we can see HNF1A, PDX1, NeuroD1, and PX4 variety had some mention, but we identified 2 variants, potentially significant variants in BLK and ABCC8, which are not there in the disease database. So these are the phenotypic features of the participants with MODY gene variants. We can see one patient had significant variant in two MODY-related genes, HNF1A and BLK, and number 5 and 6 patient have the same variant in NeuroD1. Actually, these two patients were from the same family. We can see here the fasting C peptides are good in all the participants except though in the participant with PDX1 related MODY, and she required insulin for glycemic control. Others were controlled with oral agents, specifically sulfonylurea. So in conclusion, the commonly observed MODY gene variants in the European population are not as prevalent in the current study, and the spectrum of MODY in Bangladesh and as a whole in South Asia may differ from other ethnic groups. Variants in the known MODY-related genes could explain only 12% of youth onset atypical diabetes in the study participants. So there might be yet unidentified genetic or environmental factors underlying the hyperglycemia of this group. I acknowledge my mentor and study groups of my university. Thank you for your time.
So a question from the audience. Asma.
Thank you very much. That's very interesting. In the table you showed about the family history, I didn't see consanguinity, and I'm just wondering in Bangladesh whether the high degree of consanguinity might give us some contribution, or give you some contribution to the difference between the European etiology versus the Bangladeshi
Etiology. Thank you so much for your question. Consanguinity was not mentioned because actually in these patients consanguinity was not there, and as we know the MODY are actually autosomal dominant in inheritance pattern mostly, so maybe that's why consanguinity was not a big issue here. Thank you.
Do we have any other questions? Oh, yeah.
Hi, Siri Greeley from University of Chicago. That was great. It's wonderful to see groups like yours and places like yours doing this effort to find patients with monogenic diabetes. But I just want to point out a couple things are just to clarify that BLK and PAX4 are no longer considered really MODY genes. They've been refuted really. Actually, Kash Patel, I think, is giving a talk on Friday where he will certainly cover that. And so, but of the other ones that you mentioned, the HNF1 alpha, the ABCC8, when you have VUSs like that, one thing you can do is send it to our monogenic diabetes expert panel through ClinGen, and we can review any data that might be available. I don't know if you've already done that, but there's oftentimes data that isn't yet published that the different groups will have, and when you can piece together, as you know, with the ACMG requirements for changing the pathogenicity, it often hinges upon just having a couple more cases with the right clinical data. And so I actually encourage everybody, when you have VUSs, to reach out to anyone in our group and say, hey, here's this VUS, and we might be able to help you disambiguate it.
Thank you so much. It will be a wonderful opportunity for us, and absolutely we will try to collaborate and we will share the data with you. Thank you.
Okay, so thank you. So that concludes our session. Thank you.